Hi, guys. Thanks so much for joining us. Hi, Matt.
Hey, how are you?
I'm very well, thank you. So, for you guys who are joining us, we're going to be chatting today about radioactive tin, or synovitin, as it is more commonly known, which is a little bit of I want to say new, but it's not actually new. So, Matt's going to tell us all about that. If you guys are joining us, please let me know where you are from. And if you're familiar with this product or have ever heard of it. Before we get started and jump into this chat, I am going to ask Matt a bit of a question. So I've been asking everyone this question, and it is because our theme for the Vet Rehab Summit is research meets reality. So Matt, what is the research article that you quote most often, or that has made the biggest impact on your thinking or your practice over the years?
Oh, that's a good one. I mean, there's so many, and some that have impact for a short period of time, and then others, and we always need more data. But one of the articles I always go to when I'm teaching my residents and interns is what do we know as fundamentals? And so the review article that came out with from Kristen Kirkby Shaw and Leilani Alvarez and a host of others that came out a few years ago, just reviewing what do we actually have as a standard of care for cruciate ligament rehab in vet med, is still one of my bread and butter articles.
I love that. I think we actually have a webinar where one of them chats about that, and it was one of my favorites. And now I can't remember what it was called, so I'm gonna have to think about that. Guys, please let us know where you are in the world and if you are familiar with our topic today. So we're chatting about radioactive tin or synovitin. And I see we have Tandy Clifton is here with us. Hi, thanks so much for joining us. Tandy, are you familiar with this product? And do you have any questions at any point, guys? Pop them in the comments and we'll chat about them. So Matt, if you want to tell us a little bit, what is radioactive tin or synovitin and what is its role as we understand it in the management of arthritis?
Right, it's a good one. So it's a whole new field for vet med because, but it comes under the topic of what's called RSO, or radiosynovial arthritis. And that's actually been used in Europe in people for quite some time now on a number of patients. So the concept with RSO is that we inject a radioisotope into a joint, and what that winds up doing is essentially bringing down the layer of the synovial membrane. Because what we see as OA is osteophytes. We see pain. We see, I don't know, osteophytes on radiographs. We see those changes. But the true heart of osteoarthritis comes from where it gets its nutrition, and that's the synovial membrane. So when the synovial membrane is inflamed, we get increases in metal metalloproteinases, we get upregulation in destructive enzymes, and that's what leads to cartilage damage. So what we try to do, right? What do we do with OA? We give oral anti-inflammatories to block that cascade. We may inject other things. We may inject corticosteroids or platelet-rich plasma, trying to be a targeted anti-inflammatory in that joint. But like corticosteroids will damage cartilage further, so that's not exactly helpful. And things like hyaluronic acid alone aren't as potent. So with the concept of RSO, what you're doing is going in and calming down the number of synoviocytes that are there that are inflammatory, and also the number of white blood cells, macrophages. So what we look to do with that, and for us, remember we're talking about really degenerative arthritis, secondary to dysplasia, but in people, they're also using it for autoimmune arthritis, so psoriatic or other forms of like rheumatoid arthritis. So RSO goes in and calms down that membrane. So synovitin is the first of its kind in the veterinary field, and right now only available in the United States, to go in and calm down that membrane. So what we do is we take the radioactive tin, and it's conversion electron therapy. We're not dealing with like a nuclear reactor level event. We're not dealing with I-131 that leaks into their urine or their feces. The radioactive tin material is a colloid. So we inject it by itself into the joint, outpatient, light sedation, super straightforward. And then it stays in that joint. and its half-life is 14 days. So every 14 days, it's going to be decreased by half, and it's going to stay in the joint for about 5 to 6 months. But as the radioactive tin stays in there, it's such a large molecule, that's why it can't pass back outside the synovial membrane and get into the rest of the body. So when it stays inside the joint, all those macrophages and synoviocytes recognize it as a foreign material and come over and engulf it. But when that happens, the radioisotope kills off those white blood cells, kills off those synoviocytes. So it literally puts out the coals of a campfire, right? Versus just trying to throw water on a fire. If we actually put out the coals of it, it's going to stay quiet. And that's what we aim to do with Synovitin.
Okay, so that's really, really interesting. Tandy actually says she's familiar. Her dog is in surgery right now, receiving injections bilaterally. So, Tandy, that's really cool. And I think that I was actually chatting to Meg about this the other day. I feel like us in the industry are always the first to jump on board with something that could be potentially really great for arthritis management with our own animals. We're always ready to try. So well done, Tandy. Please let us know how it goes, how your dog does afterwards. So Matt, that molecule that's in the joint now, does that you've said that it has a half-life of 14 days, but what I've read is that you're having effects for up to a year. So how does that work? And does that break down eventually, or is it remaining in the joint? Is there like a little bit of tin that stays in the joint for its entire life? How does that work?
All right, so those are all good. And I had to go back and kind of review nuclear physics to get all this back in my head. It took me a year almost of training to be able to get all the licenses and permits to get all this squared away. So the half-life is 14 days, but we're going to put in an amount that's going to stay in there until about 5 or 6 months. And the efficacy papers were done out to 12 months. So they showed that in mild to moderate cases of elbow away, 92% of the dogs injected had efficacy up to 12 months. So it's going to be there for a while. It's going to continuously kind of calm down that membrane for a while, and it will stay a little bit lingering in the joint, but it's such an infinitely small amount, right? Because it's not the tin that's trying to do anything. Right? It's not like taking a ball of aluminum foil and trying to wipe away cartilage. It's the fact that it's a radioisotope. So it's an infinitesimally tiny amount of radioactive material. So we're not causing a mechanical obstruction by leaving it in the joint.
Okay, cool. So I want to ask our listeners a question. So arthritis is a pretty big problem, and at the moment, Synovitin is only being used in elbows. Am I right, Matt?
So that's an interesting. It's been studied in elbows, and we can talk about they did safety studies too. They did efficacy studies. There's more studies coming, but it was only done in elbows in dogs. So now in the United States, not only do you have to have a federal oversight for this, but state by state, you have to have state regulatories. So like I'm in Virginia, I'm only allowed to inject it into elbows. Some of my colleagues in other states are allowed to inject it into other species and other joints with special permission.
Okay. So what you're going to be able to do depends on where you are and what the regulations are. Okay. So how many of our viewers, I want to have like a rough estimate. How many of your patients that you see have elbow arthritis? Like how many are you treating more or less percentage wise that are elbow arthritis? And I mean, that's one of the toughest things that we see because there isn't really a great treatment option for it. Okay, so for you, Matt, how many of your patients do you think are elbow arthritis?
Well, I'm going to be not in the normal.
Yes.
Right? As a VSMR, I mean, like to put in perspective, I see 8 to 10 consults a day, and yesterday 8 of those were Synovitin specific consults.
Okay.
Yeah. So I have a much different foray into this than others. But as rehab folks, we may deal with 50-50 ortho neuro. And then within ortho, do we have our post-ops? We have hip dysplasia. So really focusing on elbows probably still makes up a good chunk of my day even before we had this. And that was, you're right, because we didn't have a great option before. And we don't cure elbows. We manage elbows. We cure hips, right? How do we cure hips, everybody? 3 letters. THR, right? You cure a hip with a total hip replacement. Okay, you're done.
Yeah.
Right? Elbows, we don't cure. And in fact, there's some interesting papers that show that perhaps even in mature dogs, elbow arthroscopy to remove the fragments does not improve them. So it may not really be a mechanical defect by the time they're middle age. It really is a synovial disease. So we can attack elbows and trying to manage them, keep them a little more under wraps, and then try to see how long, do we have to repeat these in a year? I don't know yet, right? Some of the dogs in the efficacy studies were tracked out 2 or 3 years and were still comfortable after a single injection. So we still have a lot to learn, right? But
Okay.
elbows are our beast, right?
Yeah. I was going to ask that. Do you need to repeat the treatments annually, or do we, we don't know yet? Okay.
Well, so that's the interesting part, right? The efficacy papers were done out to 12 months. They were done at University of Missouri's vet school, Louisiana State's vet school, and Gulf Coast veterinary specialists in Texas. And they tracked all those dogs out 12 months. Now, when they did that, if they had a bilateral case, the study parameters only allowed them to inject 1 elbow. So we had some clients in those papers that came back and re-enrolled their dog for the other elbow. So they were able to track out a handful of cases 2 years. My goal is I have a giant spreadsheet of all my data, and I'm going to track all of my patients out for the first 100, 150 patients I see. I'm going to track them all out 24 months and see how far do I get to the 12-month efficacy in my patients? How far do I even get longer? And that'll help answer the question of, do we have to re-inject? From a nuclear medicine perspective, we're giving a dose of radiation that is an annual dose. So we can't repeat it in 6 months. Okay? We might be able to repeat it in 10 or 11 months under special circumstances. But we're basically giving an annual dose based off of the math and the safety that the company did.
Well, in terms of the options, again, that we kind of have available for managing elbows, even if it was an annual injection, that's quite manageable, right? That's quite doable. And I think most owners would be okay with that. So how many patients have you had so far? How long have you been using this?
Well, and to kind of go back to that for a second too, right? Like an annual injection is much easier because it's the same sedation, okay? It's the same amount of technician time and skill. It's the same time of practitioner time and skill to put a needle into a joint, pull out the worn out joint fluid, and put something in. That doesn't change. Depends on what product we put in, right? If we put in cortisone and synthetic joint fluid, that might get us 3 to 6 months. PRP by itself, or PRP a series, depending on the severity of the OA, might be 6 to 9 months. Stem cells, which is still a loose term and a whole nother ball of wax, gets us about 9 months, maybe 12 in some cases, depending on what we're using. So to have a study that was actually done out to 12 months is very unique. To answer how many I've done so far, by the time I got all my license and then organized and ready to go, I injected my first 3 dogs on March 30th of this year. And I injected my 30th dog by the end of June. Okay.
Awesome.
And we are busy. I have 15 dogs already scheduled for the month of July and another 15 to 20 for August and September.
Brilliant. Okay. Brilliant. Well done, Matt. It's really exciting.
We're busy.
Cool. So let's chat a bit about the licensing and regulation. You've already mentioned that it's been quite challenging. Give us a little bit of an idea of how that works and what a practice needs to have in place.
Right. And if you already have radiation in your hospital, it's going to be a little bit easier. Because if you already have a facility that does I-131, or if you're at a vet school that has, that's doing bone scans with technetium-99, this is so much easier. You're just going to have to amend your license. But if that's not the case, you are going to have to jump through some hoops on both the federal and the state level. And in order to do that, the company actually is very helpful. Exuberon's been great in putting together an online platform for all the learning and help kind of be the guide to setting things up. But you as a practice do have to file for all the appropriate permits, and they're called RAM licenses. Radioactive licenses are called RAM licenses. So in order to get your RAM, you have to put together a proposal of, this is where we're going to keep the material, this is the exact room we're going to inject it in, this is the proof that I've been trained appropriately in this. And it ships in via FedEx, right? So you have to have somebody who's regulated to be able to receive it and do all that fun things. And so you have a startup kit, right? You have your paperwork that you have to file, and then that goes in. And then you're at the whim of the regulators to get that processed and taken care of. There's about I think it was a $2,000 US licensing fee for us to get that. And then we have to have a radiation safety officer consultant. So that costs us another $3,000 or so a year. And then you have to get special materials. So the company was really helpful in getting us connected with another company to create a startup kit, which includes fun things like, I now have a Geiger counter at work, right? Because you have to have one. I have a special lock cabinet. I have lead-lined trash cans and lead-lined sharps containers. So you have to put all this material together so that you can then receive it, be safe with all this, and inject it appropriately. And then you have quarterly reviews of all your paperwork and inspections. So there are some hoops, and it will take time, but it is totally worth it. I have dogs coming off of their lifelong NSAIDs at 6 to 12 weeks post-injection. I have dogs walking up and down stairs without owner assistance for the first time in years. Like, that is huge. And if it lasts 6 months, great. If it lasts 12 months, even better. If it lasts longer than that, great. But if we have to come back to annual injections, this is a no-brainer.
So that, I mean, that's really what it comes down to, right? Is it's worth it to jump through all the hoops, to go through all of these things if it's going to make that much of a difference to our patients. That's huge. Matt, are there any studies that have compared them, have compared treatments, or compared Synovitin to other IA treatments that we have?
So we're not at there yet, but that's a good point for me to kind of jump into a couple of phases of research. So what's out there, right? First and foremost, they did a study showing it does no harm. Okay, so they had some healthy research dogs. They did not have OA. They injected it. They let it linger in there. They watched them for CBC and chem panel abnormalities, and then they did histopathology of those joints. And the Synovitin did no damage to a normal joint. Right, so it doesn't eat away cartilage like steroids do. Awesome. So that was phase 1. Phase 2 of efficacy was, how does it work? And so they have 2 studies, one that's already fully available as an open access paper, the other one's in peer review and finishing up. The first paper was the mild to moderate ones. So they graded them based off of clinical signs and radiographic evidence. And they used the elbow working group scale. So they had, 0 is no elbow problem. So of course, none of the dogs were there. 1s and 2s were in one paper, and grade 3 and 4 elbows were in the second paper. So they have those as efficacy, showing what they were looking at with that was like CBPI scores, lameness scores, and tracking all those dogs out 12 months. So there's where we've got efficacy. We don't yet have papers in a comparative data. Okay. But what I also have is I have dogs that in clinical experience that I was injecting every 4 to 6 months or 6 months with other stuff that weren't getting as good of results. And that's why I looked into this. And now that's why, like I said, I have a huge spreadsheet of every body condition score, CBPI point, goniometry point, muscle circumference point, tech scan data. Okay. My resident is going to love publishing this paper. Okay. We're going to track all these dogs out 24 months, and we're going to present it, and we're going to put it out there. And no matter what it is, right? Yeah. That's the whole point of research, right? We're going to publish it. Whatever the findings are, this is our findings.
So that was going to be my next question, actually, is like, what motivated you to actually try this? Why did you want to add this modality to your practice?
So let's all admit, elbows stink, right?
Yes,
They're frustrating.
so
They
much.
limp. They hurt. Right? We don't have good options even as a team. When I went to my surgeons, I have 6 surgeons on staff, and I said, "Hey, what do you think if we tried this?" And they're like, "Yeah, cool, because everything else stinks. Fix it." Okay? They were like, "We struggle. We can remove the fragments in the young dogs. We can absolutely go in and burr out OC, OCD lesions. Absolutely. When they're really young, take out the coronoids. Absolutely. Right? But think about it. Even in the US, out of all the thousands of dogs we all see every year with elbow away, okay? Do you know how many elbow replacements get done a year? Anybody want to throw that number in the comments section?
No idea. Do you guys
It's
do a
sing-
lot of elbow
it's
replacements?
single digits.
No way.
Single digits with a third. It's still early, and I want our surgery partners to grow and learn more. And if we can start replacing elbows with better regularity and better
Yeah.
consistency, absolutely. But think about it from a surgery perspective, we've scoped them, we've tried cues,
Yeah.
we've tried, different aspects that way. Can we do this? Can we do that? We can arthrodese them, but that's a salvage. We really
Yeah,
don't want to amputate because it's usually a bilateral disease and we like keeping legs attached.
for sure.
But right now, elbow replacements have a 30% complication rate. And if it fails enough, it can't be converted to an arthrodesis. It has to be amputated.
Yeah, it's not a great
So
choice.
that's exactly why I want to get
Yeah.
dogs off. Like, I love NSAIDs, don't get me wrong.
Yeah.
But I don't want dogs take, if they have one unilateral elbow away,
Mm-hmm.
we had one dog who has elbow away. The reason she came to us was she wound up in the ER, not eating, presumed gastric ulcer, renal failure from her NSAID from a unilateral elbow. Right? She now has permanent kidney
Yeah,
damage.
that sucks.
Which
So
those are the minors, but that's the dog that we're
yeah,
going to inject because we want to do a targeted therapy.
yeah. So Matt, what is the cost implication of this from the owner's perspective? Like,
That's
how
a good.
does having this treatment compare to the other options
Yep.
that they have?
So let's talk about this as like what, the 80 to 90 pounds, so the 40 or 50, 40 to 50 kg, the big dogs, okay?
Mm-hmm.
Because that's the one. Although I've injected everybody all the way down to a 4-kilogram pug already, and I have a 145-pound Labrador on the books for later this month.
Ouch.
Okay. So we all shapes and sizes, but let's go for that middle range, a little bit larger breed, the one we usually see. And this is separate from your consult, your blood work, and your imaging, right? This is just the day of injection because, circle this around. It's radioactive material. I don't keep this on the shelf. Everything is custom order and takes about 2 to 3 weeks or so to show up.
Mm-hmm.
So you have to do your consult, confirm your diagnosis, walk through the steps with the owners on all the pre-screening paperwork, which the company provides, and it's really straightforward. You have to make sure that all these steps are good, and then you can order the product, and then you inject it. So you've already gotten RADs because you have to confirm this, right? There's no such thing as throwing this into, is this a synovial cell sarcoma, right? We have to know what we're dealing with. But the day we inject, if we're injecting one elbow, including sedation and hospitalization, we're looking at about $2,200 US. If we're injecting both elbows on the same day, we're looking at about $3,000 US.
Okay, how is that comparing to other IA injections? Because I have no frame of reference.
I'm going to compare it to something even easier. Let's compare it to taking an NSAID every day.
Okay, great.
If it's Grapaprant for a large 80, 90-pound dog, Grapaprant every day costs an owner $1,500 to $2,000 a year. Right?
Ouch.
Okay.
Yeah.
Now, it's one of the more safer drugs, right? But they have to take it every day. And how potent is it? So we're always hard about comparing treatments is what's the potency and the efficacy. which I'll get to in a minute on some of my Synovitin dogs. But taking an NSAID every day can be $2,000 a year. So if we have one elbow and we can put it in under sedation, and then we don't have the risks of GI issues or hepatic issues, that makes a no-brainer. If they're doing other IA therapies, okay, it's going to vary from clinic to clinic and what you're putting in or things like that. But let's say bilateral elbows, probably, let's say with Depo HA, is going to be in the range of maybe $500. But if we're doing it 3 or 4 or 5, 3 or 4 times, we shouldn't be doing it more than 4 times a year. That's $2,000. Yes. And the efficacy is not as much. If we're doing, if we're doing PRP, that could be $1,000 an injection.
Okay.
If we're doing stem cells and we're harvesting fat and culturing it out and doing all that, we could be looking at anywhere, depending on what you're doing, between $3,000 to $6,000 a treatment with about a 6 to 9 month efficacy. Maybe a little bit more in some cases. So, but again, if we're in the same price point, but with Synovitin, we only do 1 sedation to inject, as opposed to, fat, adipose we have to harvest out and culture out. Bone marrow, we can still do stem table side, which is great, but sometimes we have to culture, expand that, or do other things. So it's in that same range, for sure.
Okay. Yeah, that's doable, comparable. I like it. So one of our listeners has a German Shepherd who has 2 new hip joints and 2 new elbows. Wow. So an elbow makes great problems. Sorry, don't breathe that dog.
Sorry.
Yes, please. She says she's a bionic woman. I really love that. Yeah, really interesting. Well done for being able to do that. Okay, so then as rehabbers, as physical therapists, we always need to know if you are our referring veterinarian and you have done this procedure, what are the restrictions on us when these dogs come to rehabilitation? If they come to rehabilitation, what do we need to avoid? Is there anything? What kind of restrictions are we looking at?
Yeah, and that's another good one. And the safer answer here is we don't know, so don't do it, right? We don't have papers on what Synovitin is going to be interacting with laser therapy or with shockwave or things like that. But since it's a targeted therapy, if they come to you for rehab afterwards, just don't treat the elbows, okay? Right? You're not supposed to be touching them for the first couple of weeks anyway, so they really need to go home, get injected, stay home for 2 weeks, okay? Because during that period, 2 to 4 weeks, depending on the dose, is when the dog is going to emit the most radiation that you can't be in close contact with those joints for significant periods of time. So they should be home. But let's say a month after that, they come to you for rehab. Right now, I tell my team, we're not lasering elbows that have had Synovitin for at least 6 months, okay? Because we don't want to interact and we don't know what that's going to do to the tin. But we can still laser their hips. We can laser their back. We can do other things. We can still be that global perspective of managing the patient, but we're just going to take certain things out because the Synovitin's doing its job 24/7 for the next 5 to 6 months. It doesn't need any helpers, and we don't know how that's going to. What I don't want to do is put $3,000 in of material, and then we find out that laser therapy counteracts the material and is a waste. That doesn't help.
Yeah.
The thing is, too, like I have some of these dogs that are coming back in at 2 to 6 weeks, okay, in my mild to moderate cases, that are gaining anywhere from 5 to 25 degrees of range of motion.
Wow.
That are not effused I have dogs that I'm rechecking now at 3 months, right? That are not effused at all and have been off their NSAIDs for 6 weeks.
That's insane. So Tandy has a question, which is a really great one. So her dog who's in at the moment is an English bulldog, and he uses in the CC lounge regularly. Obviously, that's treating the whole body. Should she avoid that?
So again, Tandy, and I want to have all the comparative papers, But the simple answer is, for right now, we don't know, so don't do it.
Don't do it. Yeah.
It's a great one to sit down, where we can sit down at and pull in all the specialists on all these different devices and talk about it. But if right now we don't have a paper, and so my simple answer is just don't.
Yeah. The positive thing is, if it's that effective, we don't need to use those modalities, right? So if we are you sending those dogs for rehabilitation still? Is that a part of the plan? Because in my mind, it still makes sense to say, you're still managing this elbow, right? If it's a young dog and they have their whole lives ahead of them, for the next year they're feeling great. So let's make sure that they're as strong and in as good a place as possible, so that the effects last as long as possible. So are you doing that, or is that not part of your plan at the moment?
It totally depends. So the dogs that are in my study that are elbow only, no other complications, no recent surgeries, I can't add in other things. So if they already were in rehab or they're already on joint supplements, then they can stay on those. But I can't add in other things, because then I can't say that it was only the Synovitin that made them better. So those dogs are not. And to be honest, any LVT, CCRP, CCRAs, folks that are rehab certified, we're hiring. I could use a fourth LVT rehab practitioner tomorrow. Okay, we're slammed. I think we're all seeing that. So to be honest, if I can inject them and they feel that much better that they don't have to come as often, that helps us to get in other patients that I don't have other good options for. But the other thing that's important with this is that if they need it, right? So if we're addressing their elbows, but they have horrible knees, they have, right now we injected a veterinarian's personal dog. She's now out 3 months. She's a 14-year-old pitty, okay, who turns 15 this month, okay? Horrible elbows, living on NSAIDs, right? With progressive T3L3 myelopathy. And mom was like, look, I want to try to make her feel better, right? So we injected her elbows, and she can actually move better. She's putting so much stress on her front legs because of her neurodisease that she's comfortable. So of course that dog stays in rehab, right? So we're varying them a little bit. And I might get some questions like, wait a minute, why are you injecting a 14, soon to be 15-year-old dog? It's because that was our last option. And mom was like, look, I know we can try. I'm willing to try. And for that dog, what was totally life-changing for her, and we have the data for it, is by 6 weeks out, that dog could walk twice as fast voluntarily on the tech scan. Twice as fast voluntarily.
That's amazing.
Okay? Like, that's the comfort level. And she still limps with a crazy limp, okay? Her elbows are trash, okay? But her elbows are more comfortable that she can then voluntarily walk twice as fast.
Yeah, and at the end of the day, it's all about quality of life. It doesn't really matter if they're 15. As long as they can have the best quality of life. So other than Tandy, for you guys who are listening, how likely are you to actually use this? How likely are you to try this if it was an option? Because for many of us, it's not an option yet, hopefully. So yeah.
I hope it's I know if David Lane and Jan Huntingford are on here, yes, I keep pestering Exubriant to get it in Canada. Okay, yeah. I think that's going to be the next step. But hopefully I see where people are using it, and that's really cool. We need to get it more places. But the amount of hoops the company has to jump through, like, to get it approved in each area is a huge challenge. But I know they are working on it. Full disclosure, I've been so happy working with the company, and they've been working with me, that I'm now on their advisory board to help put more projects together for this.
Awesome. I'm so glad you're with us today, Tandy. She actually says that her bulldog is 10, so it's also towards the end of her life, and she just wants a better quality of life. And she traveled 4 hours to Columbus, Ohio, to have this treatment.
Yep.
one of our Facebook users, if you guys are in the group, I can't actually see who you are, so I can read your comment, but I can't see your name. But she says it sounds amazing. And Sophie says, yes, let's get it in Canada. I'm going, yes, can we have it in South Africa, please? We're going to be way down on this.
Now, the interesting thing with the folks in Canada, right? You can check in for your, at least to send your patients, if they can hop across the border, which that's a whole different story. Hope everybody's staying safe. Yeah. Not getting into COVID right now. There's no regulation on, like, I have folks coming in from other states so they can drive in. Okay. So check in. You might be able to get clear, as long as you're not putting them on a plane, you might be able to drive across the border and get treated right now. But yeah, we need to get it in more countries for sure.
Yeah. Come to the Netherlands as well, someone says. So if I could, right? So somebody asked me this. I was consulting with a zoo veterinarian out in California about using it in a lesser kudu, which was awesome because I just did a video consult for a lesser kudu. Big giant antelope, right? Yeah.
Right. We're like, can we even use this? Can we try to figure it out? And he was like, yeah, can you just fly that out here? And I'm like, yeah, I wish I could. Right? Like we could petition it, but it's not, I have to inject it in the state of my license. I can't travel with it. Right? It comes in via, like I said, FedEx. It's very regulated. So I can't fly with it, but if you can get patients to treatment centers, it appears, at least state to state, that you can go back without a problem. So they're not regulating what state the patient comes from. They're just regulating where it can get injected.
Yeah, that's helpful. So Switzerland as well. Please bring it to Switzerland. Yeah, that's great. So Matt, are there any reasons why, like, are there contraindications, reasons why we wouldn't use this in a patient?
Absolutely. And it goes back to your diagnostic pathways, right? So would I use it in a patient that has cancer in that joint? No. Even though it's a radioisotope and technically you can kind of use radiation to treat cancer, we don't have a paper on it, right? Do not inject it into there at all, okay? If it's a septic joint, treat the sepsis first, get rid of the infection, because if you're going to wipe out all the white blood cells and leave the bacteria, that's a horrible situation for that dog. So treat what you know, get your diagnostics, okay? If they're really young dogs, okay, and talk with your surgeons, right? See where everybody's at. Because the moment you inject Synovitin, okay, if I put an arthroscope into that joint a month later, that arthroscope is now contaminated with radiation for another 3 or 4 months, which means that arthroscope can't go into another dog for 3 to 4 months. So confirm your diagnosis, talk with your surgeons. Because if you think that there's a jump down fragment, right, an acute traumatic coronoid fracture, right, that has to come out. That's a mechanical defect. If you have a really young dog that has an OCD lesion, that needs to get burred out. So know what you're dealing with. Those are the contraindications, is not knowing your diagnosis.
Okay. Okay, and for the owner taking this pet home, you've said that they need to stay home. What other kind of precautions do they need to take at home? What do they need to be aware of?
There's a whole list of paperwork that they all have to go through. They have to get pre-approved and such. And I've even had some clients that have checked in with their obstetricians, and their OBs have cleared them to have their pet injected while they're pregnant. Okay.
Oh, okay.
So it's really kind of neat that way. There's a whole set of paperwork that they go through. It's really well defined. But the big steps are no going to a boarding or grooming facility for 2 to 4 weeks post-injection. Reporting in, of course, if there's any complications or issues. And then the most awkward one, I'll get to some of the better ones, but I'll cover the most awkward one that I have to have with every client is if this pet passes away for whatever reason for the first 6 months after injection, okay? God forbid they run out and get hit by a car, they die from something else. They can be euthanized, that's not the problem. But before anything is done with their remains, they have to talk to the person who injected them, because there may be a holding delay on what, depending on state to state, on what can be done with the body. So that's the whole awkwardest part of that. But otherwise, the regulations are all laid out. And honestly, anything outside of 3 feet away, there are no restrictions. So the biggest one is that they can't sleep in bed with their owners for 2 to 4 weeks. Okay. But they can binge watch Netflix with them, but they're limited to 3 hours a day of close contact. Right?
Okay.
And close contact is 1 to 3 feet. Super close contact is less than 12 inches. That's limited to 15 minutes per person per day for the first 2 to 4 weeks, depending on the size of the dog, the dose, and their interactions at home. And they're all well laid out with pictures and diagrams and setups that the owners get before we inject them, and they get them again afterwards.
Okay.
But what's really interesting is how the government decides that 3-foot distance. That 3 feet distance is not from your foot to the dog's elbow. It's from your sternum to the dog's elbow.
Oh.
So I'm a little over 6 foot tall. So when I stand up and that pug's on the floor, I'm 3 feet away from it. So I could literally have the pug at my feet if I was working from a standing desk all day long. No big deal. They just can't sleep in bed with me for a couple of weeks. Okay, it's that prolonged contact, even though it's uber safe, and they can sleep with the other dog in the house. They can sleep with the cat, but they can't sleep with people for 2 to 4 weeks. And this goes back to every one of us has a prescribed annual allotment of radiation we're allowed to be exposed to. We're prepared to be able to have a CT every year of your head if you get a concussion, if you're out in the sun, if you're in an airplane, if you're at high altitude. There's an allotment of radiation. If you sleep in bed with your pet, you exceed that annual allotment. Okay? So that's why we can't do that, because then otherwise you can't go get a head CT, or you can't go do other things. You can't go to the beach in a plane. You need your vacation, right? Like, those are the limitations, but it's still a very, very safe product.
Yeah. And I mean, that's not too bad, but it definitely depends on the owner and the pet's relationship, because if they are very closely attached to each other, then that can be really hard. Yeah, I have one who's completely she just wants to be on me all the time, and so that would be really hard for her. And the rest of them are more than happy to be quite far away from me most of the time. So Tandy actually wants to know if her senior parents can visit her dog after her injections, if that would be safe.
Tandy, they should be fine as long as you follow your release guidelines, which you're going to get later today. Okay? As long as they're outside of 3 feet, there's no restrictions.
Okay.
Okay? And 1 to 3 feet is about 3 hours a day total.
Okay. And she'd like to know if a radiation badge would measure this.
Absolutely. So when I inject all this and I draw this up and we do this, we all have our regular X-ray dosimeters, and then I get to wear my cool secret decoder rings. I have a ring dosimeter, and so far, because we just sent those in last week, I have not gotten a red alert from our detection. So knock on wood, I've not had any contamination issues or other issues. We're really very methodical with how we do this.
Okay. Awesome. So guys, any other questions from you guys? Yeah, I'm really glad we have someone here who's having this treatment. I love to get that kind of feedback. If any of you are thinking about it, let us know as well, because yeah, it's good to have an idea just of where people are at and how they're feeling. Do you have vets that are doing this? Do are you working with referral centers that are using this this treatment, and have you had those patients come back to you? I'd love to know. But other than that, I have exhausted my questions, and basically the only other thing that I could think of is we could chat some more about the research that is coming. So you've chatted about what's been done a little bit and what we can expect. But is there anything else that's coming out that we should keep our eyes open for? Yeah.
So for sure, like I said, I'm gathering all of my data. My data will be a 24-month study. So that's not going to come out anytime soon, but I will keep everybody updated as I can on that. The safety papers are out there. They're public access. The grade 1, grade 2 paper is out there. That's already public access. The grade 3, 4 is in peer review, so that should be out soon. And then, we're going to I don't say we, I mean, I'm on the advisory board, but I'm not a percentage owner or things like that in the company, but I know the company's going to look at other areas, right? Because that's why I'm on the advisory board. I was like, hey, have you thought about using this in cats? Okay. Have you thought about using this in horses? Have you thought about, this is the conversations we have as our advisory group when we meet quarterly. It's like, where else can we use this? What other species, right? I've had clients ask me, can I get this for myself? And I'm like, yeah, but you got to go to Germany, right? Germany is the leader in this in people right now. Okay. Not specifically using synovitin, just using the same concept, the same science. Okay. But that can be done there. And then we need to see, can we use it for other joints? Right? Here's a quick, if everybody can throw it in on a poll, after elbows, what's your most frustrating joint to treat for OA? I'll tell you mine in a minute.
Yeah. What would mine be for OA? Well, I mean, the most common one would be hips, right? But it's not like you get pretty good results with it. So it's not super frustrating to work with because you can get really good results. No, I don't know. Elbows are the most frustrating.
Elbows are, and I'm glad that we have this for that. That's where I want to have it first and foremost.
Yeah. Come on, guys. What else do you guys find really frustrating?
What's your most frustrating joint?
The carpus, the shoulder. Shoulders.
Maybe. Okay.
Maybe.
I'll tell you mine. It's the hock. Okay.
Horses.
Hocks in dogs. Okay. Because we're just now, there's a couple of, depending on the size of the dog, there's a couple of veterinary hospitals in the US that can now do total hock replacements, which they're calling ankles, because you don't want to call it a THR, because that's already a hip. So it's a TAR, total ankle replacement. Okay. Nice. There's a couple of dogs and a couple of centers that can do that in some dogs. But the only other choice for really horrible, painful hocks is arthrodesis.
Yeah.
Right? So my next area to go after, I would love to be able to go after hocks.
Okay. Nice. Yeah, I do. I think that would be definitely like, can we not just limit it to elbows? That would be good.
Let's see. Always keep learning, right?
For sure. Okay, everyone, thanks so much for joining us. This has been a really very interesting conversation. I'm glad we could chat about this treatment modality. And if there are any questions from viewers who are watching this as a recording, please pop them into the comments. And yeah, Matt's online often, so we'll either tag him in and he can answer them, or I'll email them through and we can get them answered that way. Let us know your experiences. I'd love to know what your experience is with this product. If you've used it or have patients that have used it, that would be, love to know. So thank you so much, guys. Thank you, Matt.
Thank you, guys. If anybody's looking for more info, the best way to learn about this is through us, through learning stuff. The company's website, synovitin.com, has a great set of resources. And like Tandy figured out where to go to get treatment. So that's a good source for there, but always feel free to reach out, and everybody stay safe.
Bye.